Okay, so this is pathophysiology. We're going to cover chapter 16, which are disorders of the immune response. So we just went over the immune response, some of the basics of that, and now we're going to talk about some of the disorders of it. So we're going to kind of break this up. So hypersensitivity, that's where the immune response is doing more than it should, or it's doing it inappropriately. And then we'll discuss a couple of specific autoimmune diseases, even though that kind of fits into the hypersensitivity category. And then we'll talk about some immunodeficiency. Specifically, we're going to talk about HIV and AIDS. Um, and that's what we're going to spend most of our time talking about with that. Okay, so immune hypersensitivity. Hypersensitivity is just what it sounds like. Hyper means elevated, and sensitivity means that it is more sensitive. So excessive or inappropriate. So those are kind of related to one another. Excessive, we kind of understand what that means, but inappropriate means that even though the immune system isn't necessarily turned up, it's attacking things that it's not supposed to attack. So that kind of falls under this category of sensitivity. Okay, so the body is damaged by the immune system or by the immune response rather than by the antigen. So normally we are worried about the antigen coming in and doing things, but sometimes what if you have an antigen that doesn't mean any harm, just kind of finds itself inside your body, and your immune response kind of goes crazy and starts to attack that, and at the same time causes inflammation, causes some of your own tissue damage, or causes some of the symptoms associated with an allergy, or you could have complete destruction of an entire tissue, which can be obviously very bad. So there are four types. Those are listed in a table in your book, and we're going to go over each one of them individually. So they're numbered by Roman numeral, so 1, 2, 3, and 4 are the different types. So type 1, and again, this is just a brief overview before we go into them all. Type 1 is immediate. Okay, so that's a big way to understand when this shows up on a test or something like that. If it says, within a couple of hours this started happening, then you can kind of start to go in this direction and think maybe that's going to be a type 1. You'll have to look at some of the other details that we're going to talk about as well, but that's the thing. Type 1 is immediate. Type 2 is antibody mediated, which is kind of confusing because actually type 1, 2, and 3 all involve antibodies. The difference is that type 2 is more specific, tissue specific, which we'll talk about what that means, and it also involves complement. Okay, so we'll talk about what that means as well. Okay, so type 1, immediate, as we said. And this is what we usually think about when we think of an allergic reaction. Now, if you get something like poison ivy, you don't have an immediate response to poison ivy. So that means that it wouldn't, even though some people say you're allergic to poison ivy, which is true, it's not an immediate type of response. So it wouldn't be this type of hypersensitivity. We'll get into later exactly what that is. It's type 4. Um, but but these are some of the more common allergies that we think of, as long as they're, like I said, immediate. So they're mediated by IgE, immunoglobulin E, and essentially what happens is your immune system will recognize the allergen, and then the B cells will start to produce IgE. Okay, so I'll talk a little bit more about that mechanism, but local or atopic reactions, urticaria, which are hives, rhinitis, hay fever, atopic dermatitis, so inflammation of the skin, bronchial, so you can have bronchial effects, allergic asthma types of effects, food allergies a lot of times fall into this category. Again, comes down to whether it's a very fast response after having after ingesting whatever food it is. So this could result in, may also, usually it's local, but it may also result in systemic or what we would call an anaphylactic reaction. So we'll talk about what that means as well. So the mechanism. Um, the initial mechanism is just like we would expect with any other kind of allergen. So, or any other kind of antigen, any other kind of immune response. The antigen comes in, it is exposed, and then the T helper cells will then activate B cells. Okay. So when the T helper cell is initially uh, shown this antigen, whether it be by an antigen presenting cell or it just comes across it, um, it will then cause B cell activation. Now, in class, somebody asked about IgE versus IgG. As it turns out, the exact mechanism is not known why it tends to be more IgE, but it is. But IgG is also activated. So IgG is also activated. But if you don't have if you're not prone to allergies, then you may make a little less IgE. So this is if you're not prone. You may make a little less IgE and a little more IgG. And so the IgG will outcompete, and then you won't have the allergy. Now, if you are more allergic to things, specifically the allergen that you're having issues with, then you may make a little more IgE and a little less IgG. And so that's going to kind of win out, and that's where you're going to express this allergy. So, yeah, T helper cells are exposed to the antigen. They cause B cells to produce IgE. And then the IgE, and this is really, really one of the most important parts of this, is the IgE will then insert itself, or it actually binds to, sticks on little receptors that are on the outside of mast cells, and then it will activate those mast cells. I'm trying to draw that there. So then it will actually activate those mast cells and cause degranulation. So the first time that you see this allergen, you're not going to have a significant response. But the second time, now that you've produced these IgE antibodies and they've inserted themselves onto the mast cells, then the next time that you encounter this allergen, whatever it is, you'll have a larger response. So the IgE antibody coats the surface of the mast cells, and then when subsequent allergen binds, the mast cell releases its mediators. Okay, so that can lead to local or systemic issues. We prefer to have local, obviously, but local could be rhinitis, food allergies, bronchial asthma, hives, some of the stuff we mentioned before. Okay, so allergens, like I said, tends to be genetically predetermined. So most people who are allergic to one thing tend to be allergic to more than one thing. So are commonly allergic to more than one allergen. And something that they've seen, they're not sure why, but they tend to have a higher concentration of IgE. Okay? And furthermore, on the mast cell may have more binding sites for the IgE. Okay? So they're kind of set up to be a little bit more hypersensitive. All right, so examples, again, food allergies, allergic rhinitis, allergic dermatitis, forms of bronchial asthma, pollens, molds, fungi, foods, animals. Yeah, I just listed it over and over. Even though it's pretty broad range, you kind of get the point. So the allergen may be contained within a particle too large to be phagocytosed or is protected by a non-allergen coat, hence the need for eosinophils. So I'm going to go back to the previous slide, and we can see that another thing that happens with this are eosinophils are activated. Okay, so the activation of eosinophils will then help break down sometimes if you have a large piece of pollen with a coat around it, then the eosinophils are able to take that out. And of course, eosinophils also release histamine, which increases that response. Okay, so remember, we're still talking about type 1. type 1. So we're still talking about type 1 hypersensitivity, but type 1 hypersensitivity has a couple of phases. And the first phase is what you would call, makes sense, the initial or early response. It occurs in 5 to 30 minutes, maybe even quicker, and it lasts about 60 minutes. And then it kind of starts to fade away, and that early phase is done. So what's going on is you're having this mast cell degranulation. So the allergen is binding to that IgE, causing the mast cell to leak its granules, which is causing vasodilation, vascular leakage, kind of these inflammatory types of responses, and smooth muscle contraction. Okay, so that sort of makes sense. But then after this histamine, so histamine is one of the primary causes of some of these things. But then after that kind of goes away, and you know, the histamine's not going to last very long, and it trickles away. One of the things that happens is it triggers the cells to actually start producing other mediators, and we've talked about these lipid. We use this generic term lipid mediators, but those are the prostaglandins and the leukotrienes. Now, I don't have the picture up here anymore, but these guys tend to last a little bit longer, and they tend to take over the role of these first mast cell degranulation. So they'll continue the bronchial contractions, which is going to lead to some of the effects of like asthma, and that's why leukotrienes are implicated in asthma, because they turn that on, and then they start to cause this bronchial constriction. The prostaglandins are going to, you know, continue some of these inflammatory responses. So there's also an increase, because remember, white blood cells, they need a signal first, and then they need to get to the place where whatever has happened. So you have an increased infiltration of eosinophils, which then leads to the destruction of epithelial cell components. So the eosinophils get in there, and they start to break things. They start to kill whatever cells maybe in the area. So and they also release their mediators, which are going to cause some of these things: mucosal edema, more mucus secretion, more leukocytes move in, epithelial damage, and the bronchospasms, which the bronchospasms, we can kind of attribute that to leukotrienes. All right. So anaphylaxis. A lot of us have heard about anaphylactic shock or something like that. And while anaphylactic shock is a real thing, kind of mentioned that down here, anaphylaxis itself is just systemic type 1 hypersensitivity. So that's when it stops being local and it becomes systemic. So that's the way that's expressed. Usually, like I said, it stays local, but what happens is something just has to make it into the circulatory system. If it makes it into the circulatory system, it's going to be moving throughout the body. So we have here often a result from injected or ingested allergens, which makes more sense. It's not going to kind of remain in that interstitial tissue. It's kind of going to move out to the entire system. So oftentimes only a small amount of allergen may be required to produce the reaction, because your immune system is very, very active to it, and just because it happened in one location doesn't mean that you wouldn't have been active. Let me see if that can make sense. Just because it happened here, you know, in the arm here, doesn't mean that if it happened here, it wouldn't also be active. So once it starts moving through the bloodstream, you can have reactions all over the place. Okay, and when we think about these reactions and what's actually happening when it goes systemic, a lot of it is just the vasodilation. You also will see bronchoconstriction. So even though you may have had something happen in one area here, then suddenly you have this effect on the lungs, and you may have this dyspnea or this labored breathing, quick shortness of breath, wheezing, even though the offender was somewhere completely different. It's because it went systemic. Vasodilation decreases blood pressure. You suddenly go from having this nice closed system that only has a certain amount of area in which the blood can flow to vasodilation, and your blood pressure will simply just drop. Okay, so that's a possibility. Blood pressure might drop a little bit, but if it drops too much, then we end up with this anaphylactic shock. Now, cardiovascular shock, circulatory shock, indicates that you've got a decrease in blood pressure to a dangerous level. And so, oops, I never changed this. Vasodilation. So this should be vasodilation. I really need to go back and change that. Vasodilation and loss of fluid is exudate. So when the capillaries become more permeable, the fluid and some of the proteins and products can move out into the interstitial fluid, and that's going to produce this exudate, which takes blood. Not only are you giving the blood much more room, which is going to lower the blood pressure, but you're also allowing some of it to leave. So that's what's going to create the shock, and shock can be life-threatening, because then it can cause other cardiac issues with trying to pump your blood. Some of the stuff we'll talk about when we talk about the cardiovascular system. Okay, so overview of the allergic reaction. The body is exposed to an external substance like an antigen, and the immune system interprets the antigen as a foreign invader. Okay, it's not. It might be, but the immune system is, like I said, hypersensitive. So in allergic individuals, the immune system then makes an unusual or hypersensitive response that harms the body. Sensitization occurs. So initially there's not much going on. You won't have a reaction, but sensitization does occur, and the plasma cells start to produce this antibody. Specifically, they produce large amounts of IgE that binds to the mast cells, and then those mast cells, when the allergen comes back into contact with it, will release their mediators, their granules. And we've discussed that histamine is an example of a mediator. That's why we take antihistamines a lot of times for an allergic response. We take an antihistamine. Histamine is released, okay, from the mast cells, along with some other cytokines and some other molecules, and it binds to histamine receptors. Okay? Well, if we take an antihistamine, we block those receptors. So no binding of the histamine can take place, and it kind of short circuits the allergic response. Okay, it's the effect of the mediators on the organs and cells that cause the symptoms of an allergic reaction. Allergy shots. Now, allergy shots, what they desensitize by turning down the immune response. Well, how do they do that? If this is a mast cell and this is an IgE antibody, well, what happens is you inject the actual antigen, the actual allergen, into the body, and that's going to cause an increase in IgG. And if you turn up the IgG levels, which is a lot of times what, like I said, what we see with people who don't have allergies. They have more IgG, less IgE, and so you kind of return it to that level. So then when the allergen comes in and it's going to bind, it wants to bind to the IgE, the IgG might intercept it, and then you don't have the binding, and so you don't have the allergic response. So a lot of times it takes several injections to do this, because the body's own propensity is to not produce as many of the IgG and produce more of the IgE for whatever reason, and so you kind of have to keep turning it up and reminding it to produce the IgG. Okay, let's see, did I go through everything? Next exposure, less severe reaction because the IgG is attacking the allergen, makes it less able to bind to the IgE. Yes. So, type 2 hypersensitivity. This is what we call antibody mediated. Okay. We call it antibody mediated. I know I just went through and was talking about antibodies IgE, but this one is specifically antibody mediated in terms of the antibodies are actually doing the harm. The antibodies are actually attacking something. So usually the antibodies that we're thinking of are going to be IgG or IgM. Okay, remember IgM are the ones that look like the snowflakes. Okay, and IgG, of course, are the ones, the soluble ones that we normally think about. All right, so because IgM are associated with the ABO blood group, but ABO doesn't have antigens, and IgG, a lot of times you'll see that associated with like Rh factor. So oftentimes it involves the antigens on red or white blood cells. Okay, so a lot of times it's just going after blood cells. So that's going to be involved in things like transfusion reactions. So you give blood or someone gives you blood, and then you find out that you're not the right blood type. Of course, that's usually remedied, and we usually check for that nowadays. Rh disease. So, like I said, if mom is Rh negative, that means she can produce antibodies against Rh, against the Rh antigen. Well, if baby happens to be Rh positive, she could attack that if she's exposed to it. Okay, and of course the IgG is permeable. So, and a lot of times drug reactions. Okay, so we'll talk about how penicillin may actually bind to the blood cells. Okay, so it may actually bind to the blood cells down here, and then your antibodies may come through and recognize that and then attack the blood cell itself. Okay, so mechanisms. Tissue specific leads to complement, so complement also gets involved. It's basically just a normal type of immune response at that point. Once you're making the antibodies, then it just kind of goes through this normal immune response. So complement-mediated phagocytosis, inflammation, cell injury, or physiological responses without cell injury, and we'll talk about one of those. And so if we look at this first one, the first one is our antibodies that show up on red blood cells. Okay, so the antibodies show up on red blood cells. They're going to trigger some kind of a reaction. So that's going to trigger the immune response. B, complement mediated response. So this is an instance where there's a cell surface and you have activation of the complement system. So um, you may have binding of the antibody, and then the antibody will trigger the rest of that complement system. And of course, the complement system pokes holes in the membrane, and that causes leakage, and that can cause tissue death. Now, that's fine if it's a pathogen, but in this case, we're talking about a hypersensitivity, and so this antibody binding and labeling your own tissues isn't so good. So then when the complement comes down, it's killing your own tissues. Now, physiological responses without cell injury, that's going to be the example C, which is what happens in Graves' disease. Graves' disease, the antibody actually stimulates the thyroid receptor. So you have a receptor for thyroid stimulating hormone, which is released from the pituitary gland, the posterior, or the anterior pituitary, sorry. So the anterior pituitary normally releases thyroid stimulating hormone, but you, for whatever reason, or the person, is making antibodies against the thyroid stimulating hormone receptor. And it's not just that, but the antibody is actually activating the receptor. So it's turning it on. It's turning it on, and so this is starting to produce thyroid hormone. And that's going to cause an overactive thyroid gland. Okay, so D is myasthenia gravis, and that is where it's the same type of deal. You have antibodies that are attacking the receptors, but in this case, they're blocking them. They're sort of working as an antagonist. And if they're doing that, this is the what we see here. in this image for D is we see a motor neuron coming down saying, oh, I want this muscle to be activated, so it's trying to turn on this muscle or activate this muscle, but it can't. The acetylcholine is released. There's an antibody there which interferes with its binding, and it doesn't release. And so, or it doesn't bind. So it can't activate the muscle. And so if someone with myasthenia gravis were to try to pick up something heavy, and they may be trying as hard as they can to activate their muscles, but they just can't activate all of the muscle fibers that they need to. And so that's going to present as a weakness. Okay, so muscle weakness. So hyper 2 sensitivity, still talking about type 2, complement and antibody mediated cell destruction. So remember that it involves complement, or can involve complement, or it can involve antibody mediated. The IgG or IgM binds antigens on the cell surface, and we already talked about certain tissues. Okay, so this is going to be tissue specific because, so make a note of that, because this is going to be one of the kind of important things that are going to allow us to distinguish between these types. But this is tissue specific, and that kind of makes sense because it's antibody or it's antigen specific. It's actually finding a particular antigen and attacking it. So if a tissue expresses that particular antigen, then that's the tissue it's going to attack. So on tissues, Graves' disease, myasthenia gravis, that we've already mentioned. There's another one, Goodpasture syndrome. Goodpasture syndrome tends to attack blood endothelial tissue, and you have a lot of that in the glomerulus, where the glomerulus is that little capillary ball. Do you remember that? The Bowman's capsule, all that stuff in the kidney. And so this little capillary ball, it tends to attack that and then can wipe that out. And there's also vasculature in the lungs, and that can also attack those, and it can wipe out certain areas of the lungs, which can cause a big problem as well. So that's Goodpasture syndrome. And the one that we more commonly think about, red blood cells or white blood cells, but on the red blood cells it's AB and RH. Okay, so transfusion reactions, we already mentioned that, hemolytic disease of newborns, and then the drug reactions that I mentioned where penicillin coats, I already drew this out once, so I don't really want to do it again, but I can't seem to stop myself. And so the penicillin coats the red blood cell, and then the immune system attacks that. Okay, kills the red blood cell. All right, so ABO blood groups. Remember, these are the IgM antibodies. If you are blood type A, and this is confusing, but it's something you have to understand. I don't want to spend a lot of time on it, but if you're blood type A, are you going to be making antibodies? If everything is working properly, are you going to be making antibodies against blood type A? No, you're not. But if someone with type B, blood type B, donates blood to you, yes, you're going to make antibodies against it. And so that's why we see antigen. You have to understand these terms. Antigen. Type A blood has the type A antigen, which means that if it's your blood, you're not going to produce antibodies against it. You're going to produce antibodies against B. Okay, so you'll produce anti-B. This is confusing sometimes, but don't let it be. It's actually pretty straightforward. Once it clicks, it just kind of makes sense. If your blood type is AB, you're not going to produce antibodies against either one. Okay? You'll have, because you already have the A and B antigens, and you don't want to produce antibodies against your own blood. If you do, you're going to die. You're not going to be able to survive. Okay? At group O, you don't have either antigen. Okay? So that means you're going to produce antibodies against both. Now, remember that, and I sort of started to say this, I've said it before, but IgM, these large snowflake ones, can't cross the placenta. So that means that baby, even though baby is type B blood, and maybe mom is even making anti-B antigen, or antibodies against the baby's blood, it won't really matter. It does in some cases. In some cases, yes, there is some leakage, and mom will attack baby's blood to some small degree. But normally, no, the IgM doesn't pass and baby is safe. However, Rh factor is IgG, and IgG can cross the placenta. So keep that in mind. All right. Type 3 hypersensitivity is, I don't know, I guess a little more confusing, mostly because what tends to happen is you form the antibodies against something, and then these antibodies will circulate. They circulate in the blood, forming this immune complex. Okay, so you can kind of see that here. Here are the antigens from wherever the antigens came from. It could be one of your own body's cells that are producing antigens. It could be something from the outside that is producing these antigens. But either way, the antibodies will cling to these and they form this complex. And this complex can then, I guess, either it's already rolling along the surface or it moves to the surface and it embeds itself in the tissue or in the cell. And so what it's doing when it does that is it's actually labeling that cell for destruction. And so the other parts of your immune system, so attraction of inflammatory cells, this looks like a neutrophil is coming down and it's going to kill the cell. By killing this, so even though, and we say this is not tissue specific because it really didn't matter, and that's why it's not tissue specific. This complex didn't care what cell it landed on. But since it's in the blood, it tends to attack endothelial cells, so the epithelial cells lining the blood vessels. And so it tends to fall out of solution there, and it tends to fall out of solution in specific places. Um, so the mechanism, circulating immune complexes deposit on walls of blood vessels and activate complement. So even though it's not tissue specific, because of the mechanism that it uses, it tends to be in the blood vessels. Leads to recruitment and activation of inflammatory cells that decrease tissue damaging products, that release tissue damaging products. Blood vessels are damaged. Okay, so ultimately that's usually what it's causing to happen. So again, antigen-antibody complexes are formed in circulation or later deposited in vessel walls or extravascular tissues. Damages blood vessels, ultimately may damage the kidneys. So again, we go back to this glomerulus. So we have glomerular nephritis because that's kind of this filtration point. So that's kind of a place where it makes sense as it's moving in. So there it's going, and then it will fall out of solution in here. That labels that glomerulus, and that glomerulus is destroyed. It also tends to move into joints for whatever reason. It tends to collect in joints and causes rheumatoid arthritis. Okay, so the exact mechanism of how rheumatoid arthritis happens is not really known, but they know that it starts out as this type 3 hypersensitivity, and you see this deposit of these immune antigen complexes, and then the body will attack those and it damages the joints. So it's not organ specific because it isn't attacking a specific cell type. Most common causes are antibiotics, but also food, drugs, insect venoms, whatever is going to cause some kind of a free-floating antigen to appear is going to result in this type of hypersensitivity. So some examples: autoimmune vasculitis, so that's the vascular system, so that kind of makes sense, inflammation of the blood vessels. Glomerular nephritis that we just mentioned, systemic lupus, also originates as a type 3, and then rheumatoid arthritis that we just mentioned. We'll talk more about lupus in a minute. Okay, so type 4 hypersensitivity. This is delayed. It's delayed, and this is the only one that does not include antibodies. No antibodies. And it kind of makes sense that it doesn't when we think about what's going on. So it's cell mediated, so that means there is some kind of cell somewhere out there that has an antigen that the immune system responds to, okay, for whatever reason. So the T cells are going to respond because remember T cells attack cells, they're cell-mediated immunity, and so here's this T cell that will then recognize whatever this antigen is inappropriately. And so as these T cells, the T cells are also found in the periphery. I know we talk about lymph cells existing in the lymph nodes, so T cells, B cells existing in the lymph nodes, but I think a good analogy to that is that most people are in cities, but that doesn't mean that they're not scattered all over the place. And that's the same thing with T cells. They're scattered all over, but they tend to collect in the lymph tissue. So they direct cell-mediated cytotoxicity, so T helper cells can send out a signal saying that something is going wrong. Cytotoxic T cells may come in, and also these may recognize it and destroy the tissue. Viral reactions may cause this to take place. We'll talk about some of how the immune system gets confused. And ultimately it may involve macrophages. So ultimately this may be labeled to as these are signaling responses, then you may have macrophages may also come in later, but the macrophages may also initially engulf it. They may also initially engulf this. So what if it's just a dying cell, and then macrophages? So here you have a dying cell for whatever reason, and then the macrophage comes in and phagocytoses it, and then presents that antigen, chops it up, and presents that antigen on the MHC to the T cell, and the T cell says, normally this macrophage would say, whatever, or the T cell would say, yeah, that's one of ours, we don't care. But if this T cell does respond, then it's going to trigger more of a response. Okay, it's delayed because it takes a long time for all of this stuff to happen. It takes a long time for a T cell to notice that it's there in the first place, and so then it kind of, once it does notice, then it starts to generate this more active response. So contact dermatitis, things like poison ivy, nickel allergies. Um, so these molecules will collect, they'll build up, usually they're local, and then the T cells move in and cause the inflammatory response. The PPD or the TB test, that's the same thing. You put it in locally, and then you check to see if there are T cells that are already responsive to it. And if they're responsive to it, they move in and they will cause that secondary type of response, that inflammatory response. MS, so this is a case where you have myelin cells that are surrounding neurons that, for whatever reason, have an antigen on them that the body recognizes. Type 1 diabetes, the same thing. The alpha cells, they have these antigens on their surface that the T cells recognize, and then they will cause more of a response, and they will take them out. Okay. So again, this is the only hypersensitivity response that doesn't include antibodies. So the mechanism again. So we see here an antigen presenting cell that could be a macrophage, takes it in, and then tells the T cells that it's an inappropriate response. CD8 cells may recognize it as being an inappropriate antigen, and it's wrong, of course, but that doesn't really matter to your beta cells, for instance. And then they release the cytokine, and then you have more of a response. So CD4 T cells delayed, or CD8 T cells cause cytolysis, breaking them down, leads to sensitized T cells, which cause cell and tissue injury and the release of inflammatory factors. So here we can see kind of an example. The catechol molecules from poison ivy then will interact with proteins in the skin, and that's going to label those particular cells as foreign, and your T cells will then come down and try to destroy those, and not just destroy those, but also create an inflammatory response. Okay, inflammation. Okay. All right, so this is an overview. I'm not going to go through each one of these, but I've kind of put some of the things that we've already talked about to just kind of give you another perspective in putting them all in one place and having some examples of the drugs and the responses. So I'm not going to go over that. So let's talk about graft rejection. Solid organ graft rejection. This is, I mean, this sort of falls into the category. I mean, it's going to fit one of these types. It's a hypersensitivity, but it's kind of a special hypersensitivity because what you're doing, first of all, it's kind of a problem. It's not just like a small little reaction, and it's not your body doing it to itself. You're actually putting something in, and you want your body to not react to it. And so, but that isn't always the case. And so it's very interesting and clinically important to figure out what's causing this. And so it's good to understand it. So solid organ rejection, so you give somebody your kidney, there's a T cell response, which sort of indicates that this is going to be a type 4. T cell response leads to endothelial cell death. Endothelium, when we think endothelium, we think the inside of blood vessels. Okay? And the reason that it's the endothelial tissue is that when you hook up, for lack of a better term, an organ, you have to attach blood vessels. Okay, it needs a blood supply. So you may be attaching that blood vessel to the host. Now that means that, so if this is our new organ here, this is the host, and so this is what the immune system is going to see. One of the first things the immune system is going to see. So it usually ends up attacking the blood vessels, the endothelial tissue. And that's going to lead to ischemia. If you destroy the blood vessels, you're not going to be able to get those tissues oxygen or any other kind of nutrients. And then, so ischemia of the organ and triggers inflammation, which the inflammation itself in the remaining tissues prior to necrosis is going to increase vascular permeability, local accumulation of lymphocytes, macrophages, and then ultimately, yes, it's going to kill those, and it's going to wipe them out. Now, when you think about rejection, so when you go through you have a donor organ and you do the transplant surgery, well, one of the first, there are 3 forms of rejection. So the first thing can just be you got the blood type wrong, and that's hyperacute, or it could be that for whatever reason the host, the one that is getting the organ, already has circulating antibodies against something that's in that organ. Usually it's the blood type though. And so if they already have antibodies that are circulating, so even if they're a blood type mismatch, it may not happen right away, but if they already have circulating antibodies, then that may show up right in surgery right now, and that's a complete rejection. You have to stop the surgery. So that's going to be more along the lines of a type 2 hypersensitivity. So that's antibody mediated. Acute is the most common, and that tends to be where it starts to recognize the tissue. Okay, so it starts to recognize some antigen, so type 4 hypersensitivity, it starts to recognize, T cells start to recognize some kind of antigen on the cells that have been implanted. And so the destruction can be from antibody. Okay, so that's another possibility. You could have a full-on, that's why I say it tends to be type 4. You could have a full-on immune response, which is going to be, fairly quick, or it could be also this cell-mediated. Okay, so it could involve the complement system. Okay. But again, the target is usually the blood vessels. Okay, so it tends to be Type 4, T cell mediated. T cells move to location, release signals to trigger other immune responses. Okay, so chronic rejection. Not really sure. Not really sure what's going on with chronic rejection, but that tends to be slow and progressive, and you can kind of you can kind of tell by looking at the organ that you have some atrophy, or the organ is getting smaller, and almost like it's aging more rapidly. So and there's really no treatment for that. Okay, so graft versus host disease. So I pointed out the graft is what is coming in, and the host is the person that is getting it. So who's attacking who? In this case, it's the graft that's attacking the host. So before, when we were talking about solid organ graft rejection, that's more of a host versus graft. This is graft versus host. So that means, and it kind of makes sense because it really largely involves bone marrow transplants. And why do you get a bone marrow transplant? Because your own white blood cells usually aren't doing the job. They're not producing the white blood cells. They're not. They could be uh, cancerous, and so they're not producing healthy white blood cells, which means that your immune system is failing you. Well, so what happens is that you get a donation of bone marrow from someone else, and their immune system is presumably absolutely fine. It gets into your body and kind of tries to take over. So it occurs mainly in bone marrow transplants with immunocompromised people. Okay, so if they receive blood with an HLA, which is the same as MHC, but when we're talking about donations, we tend to talk about HLA. So with HLA incompatible lymphocytes, yeah, I already wrote that here. So that's if you're not a match, if you're not a good match, then the donor bone marrow could actually start to recognize your tissue as being a little bit different MHC, and so it's going to launch an attack. So the donor T cells and natural killer cells will attack the host HLA antigens, which tend to be on all of your cells. The MHC1 is on all of your cells. So it presents as a pruritic, itchy skin rash. It can cause severe pain of the skin. It can cause joint problems. It can cause a lot of different problems. And sometimes, it's a very common. Graft-versus-host disease is very common. But sometimes it doesn't last very long, and it's common. Like I think it's like 70% of recipients will develop some form of graft-versus-host disease, and sometimes it's more serious than others. Sometimes it can be life-threatening. Okay, so what do you have to have for graft-versus-host disease, GVHD, to develop? Well, the transplant has to have functional cellular immune component. So whatever bone marrow you're getting has to be functional in terms of its ability to launch an immune response. The recipient tissue has to have something for it to attack. It has to have some kind of foreign antigens that the donor's tissue doesn't like. And the recipient isn't going to be able to fight back. Okay, so it's not going to be able to fight against the bone marrow that's coming in, because that bone marrow's immune cells are stronger, and so it's not able to fight back and take that out. Okay, which could actually be a worse situation. Okay, so again, T cells, natural killer cells react with the bone marrow transplant recipient. All right, so some specific, let's see, I guess general autoimmune disease. Normally, it's self-reactive immune cells are destroyed or suppressed, so that means that that's what's normally supposed to happen. You're not supposed to produce T cells that react to self-antigens. But in autoimmunity, self-tolerance breaks down and the immune system attacks itself and destroys body tissues. So normally we have this self-tolerance, which is the inability to mount an immune response against your own body, against self. And that's how things should function. So now this could happen: central tolerance, peripheral tolerance. Central tolerance just means that you're eliminating it in the thymus and the bone marrow. Peripheral tolerance, a lot of times these immature T cells will move out, and we do have a sort of a backup plan where these can be eliminated later on. If they respond to some self antigens and there isn't enough antigen to really activate it, then a lot of times these T cells that respond to some of these self antigens will be destroyed, and that's peripheral tolerance. So if they escape detection early, then your immune system can actually take them out. Now, mechanisms of autoimmune disorders, I mean, where do they come from? Who gets them? Why do they get them? A lot of times it's a genetic predisposition. We don't know why. Okay, so some kind of genetic predisposition, if you have identical twins, one person develops an autoimmune disease, the other person may not, but has a higher chance of developing the same autoimmune disorder. So it could be that there was a virus that one was exposed to. It could be that there was an injury where some kind of, antigen that was supposed to be sequestered suddenly showed up, and that could have triggered it. So it's really not known. All we know is that there is a genetic element to it. Estrogen is kind of another one of these things. We know that many autoimmune diseases are more common in women than men. And so one of the first things to blame would be estrogen receptors. And there's been a lot of studies kind of supporting that. I don't mean to dismiss that as being not likely. It's just that there is still some controversy over exactly what estrogen's role is in that. But we do know that more women than men suffer from a lot of these autoimmune diseases. Breakdown in cell energy. Energy, that's not a typo. That just means the absence of the immune response. So that basically means that immune cells that aren't supposed to be attacking self start to attack self. Okay, so that means that you're supposed to shut them down, and they're not being shut down. So that's the breakdown in that we're talking about. Release of sequestered antigens. So I just kind of mentioned that. We have a lot of molecules that are in the brain, and that can serve as antigens. And we have in the eye, sometimes there are some areas of our body that the circulatory system and therefore the immune system just simply never see. But if there's an injury and it leaks out, then the immune system can see it and can respond to that. Okay, so it's kind of like the baby growing in mom's belly. Its blood is not supposed to be seen by the mom, but sometimes that can happen. Another example would be like sperm. Sperm cells are supposed to be hidden from the immune system for the most part. But if there's an injury, I don't even want to think about that injury, but if there's an injury whereby sperm cells suddenly start to move out into the circulation, well, your body is going to launch an immune response, and it might produce IgG, which then can kind of cause damage, further damage. Okay, so molecular mimicry. Sometimes, and this one's kind of interesting, sometimes you have a disorder, an autoimmune disorder that occurs maybe after a certain virus. We talked about that with like the Epstein-Barr virus. That sometimes it can trigger an autoimmune response later on. The body fights against it, forms antibodies against the virus, and then that looks enough like some other antigen in some other protein in the body that it starts to attack that protein as well. That's been implicated in things like type 1 diabetes, that maybe there's some foreign antigen that gets into the body that tricks those T cells into thinking that the beta cells are harmful. Okay, so that one's kind of interesting. And then super antigens. Well, sometimes there are certain bugs, certain bacteria that produce antigens that just trigger a huge immune response against them. These are super antigens, so it's a family of related substances that can short circuit the normal immune response. By doing that, so leading to inappropriate activation. So we try to make sense out of this. Processing and presentation by the antigen presenting cells is not required. It will directly activate T cells. So these T cells are immediately turned on, and then the T cells will start to proliferate wildly. And if those T cells cross react with something in the body, then that can cause things like toxic shock syndrome, Kawasaki's disease, but it causes a immune response, okay, or an autoimmune disorder. Okay, let's see. So here are a couple of type 3 autoimmune examples. Systemic lupus, we kind of already talked about that. Um, essentially, what's going on with systemic lupus is some kind of body. It seems to be body specific. It attacks a number of different cells. It's actually DNA that it sort of forms an antibody or an antibody against, and so you have this buildup of these complexes. Okay, the antibody antigen complexes that we were kind of talking about, and that can then cause it to fall out of solution. So anything that breaks free, anything that moves out into circulation, or it could actually just sort of it could happen in the interstitial fluid, wherever it happens, it causes it tends to affect either the circulatory system, or in some cases, like I said, if it moves out into the vascular or the interstitial fluid, it causes joint pains. And actually, if you look at this, 90% of individuals experience joint pain and arthritis. Okay, and then 70 to 80% also have the vasculitis and rash. So it's not really tissue specific. And it tends to be mediated by blood flow. All right, rheumatoid arthritis, a little more direct. That's a little more specific and tends to just present in joints. And so that's, again, where circulating immune complexes containing antibodies will collect in the joints. Okay, it's more common in females: redness, swelling, painful joints. So we don't know why these things express differently. Obviously, it has something to do with the location of the trigger, whatever types of cells or whatever types of antigen are triggering them. It has something to do with that, but it's not really known, and that's kind of what they're studying. Okay, so immunodeficiency. So we've just kind of covered a lot. We spent a lot of our time talking about overactive hypersensitivity or hypersensitive immune response, and so now we're going to talk about immunodeficiency. Um, Roughly broken down into a couple of categories. Primary, when we think of primary immunodeficiency, that we tend to think of genetics, and so that means that we have here listed humoral or B cell deficiency or cellular T cell deficiency. For whatever reason, some kind of a mutation is causing a deficiency in your ability to produce, or the part of the maturation process. Somehow your B cells are underrepresented, or your T cells are underrepresented, or in the case of severe combined immunodeficiency or SCID, okay, then both are limited. Okay, that's kind of a genetic cause. Acquired is a consequence of some other event. So malnutrition, immunosuppressant drugs. So something has caused you to suddenly stop producing antibodies. Stopped you from producing these B cells, T cells. And the one that we're going to talk about is AIDS, or HIV, human immunodeficiency virus. And so, yeah, so we're going to talk about HIV, and human immunodeficiency virus is the actual virus. Okay, So that's the actual virus that will attack and infect. It's called a retrovirus, and it's important that you understand this. Mostly it's important that you understand that it's a retrovirus because most of the drugs are antiretroviral drugs, and you can't understand what an antiretroviral drug is unless you understand what that means. So essentially, briefly, what it means is that the DNA, or in this case the RNA, turns into DNA and then uploads itself into the host. Okay, so I have an image on the next page that shows that a little more clearly. And they tend to affect CD4 helper cells, helper T cells. Transmission, so a lot of the fear early on was that nobody understood really how it was transmitted. Was it transmitted through, if you sneeze on somebody, or, can you inhale it? If you brush up against somebody that's HIV positive, can you get it that way? And so that's not the case for most of those things. It's transmitted by body fluids. Sexual content tends to be one of the main ways. And breast milk, and somebody asked me about breast milk and how transmission could occur through breast milk, and of course it's not really known how that takes place, but it is known. They've done a lot of studies showing that the breast milk can transmit. Blood-to-blood contact, contaminated needles, transfusions during pregnancy or birth, and so anywhere where blood is being exchanged, there can be a transmission there. Semen, that kind of goes back to sexual contact, semen, vaginal fluid. HIV, like I said, HIV is the virus, but HIV is what can cause AIDS. So AIDS is a disease that is it's caused, or so it's defined by a CD4 count of less than 200. Okay, and that's 200 of these viruses per cubic centimeter, or I'm sorry, CD4, not the virus, but the CD4 cells. So less than 200 per cubic centimeter per milliliter. Same thing. That's when HIV has caused AIDS. Now, it infects cells, and we're gonna kind of go through the steps of how this takes place. And they're labeled 1 through 8. So whoever wrote this up decided that 1 through 8 was a good number, and it is, because you can see that if we think about this. Okay, so HIV, so some kind of sexual content, whatever it was transmitted. So that virus has to make it into a cell. Okay? And so T cells tend to express these external signals on the outside of their membranes. And even though this signal its purpose wasn't to attract HIV viruses, the HIV viruses will take advantage of this, and some other viruses also, like the plague, flu viruses. Everything that's going to infect a cell needs somewhere to first bind and then move in. And so HIV is no different in that respect. There are people with mutations in some of these, particularly I think it's the CCR5, that aren't able to, they can't, the virus can't bind to it, and so the virus just kind of floats away. But most people have this binding site, and then that causes the virus to move into the cell, the T cell in this case, and that's where you have this reverse transcription. Okay, so you have something called reverse transcription, and the inside of this is a nice picture. So the inside of HIV has RNA. Okay, so single-stranded RNA. Now, single-stranded RNA, we have double-stranded DNA. So there's this little process called reverse transcription, and it uses an enzyme called reverse transcriptase. And the reverse transcriptase will cause that mRNA to form double-stranded DNA. Okay? That's quite a trick. It's a nice trick if you're an HIV virus. Not so nice if you're the victim. And then that DNA, that newly transcribed DNA, will insert itself into the host DNA. So does that make sense? A couple of things had to happen. Reverse transcription of the RNA that was part of the HIV. So reverse transcription to produce DNA, and then the DNA moves into the host DNA, inserts itself right in there. So that means that every time the host has an immune response or whatever it's called a promoter is activated and starts to transcribe the DNA, it will also transcribe virus particles. And then these virus particles will move out. So it's using the cell's own transcription translation processes against it. So it will produce this polyprotein, this long chain protein, and then it will cut those up into little pieces to produce more virus. The virus moves out, and then it can go in and affect another cell. Okay, so it starts the whole process over again. So this is kind of these are the steps right here. So binds to the CD4. So you can kind of go through these. I don't want to go through it again, but that's kind of everything that I just mentioned. So ultimately, what happens is it kills the CD4 cell. So the production of more and more of these viruses and the parts of these viruses can actually lyse or kill the CD4 cell. Now, sometimes, so what initially happens is that your immune system will get a hold of this and it'll see it. Okay, so these viruses start to move out. You know, they're moving between. So if here's a CD4 cell, it escapes and it moves in between, and it's trying to get to another one. But that doesn't mean it won't be swept away by the lymph, or it moves around in the body. And the B cells will see it. The T cells, of course, are going to also recognize it at first. And so that's going to launch an immune response. And so you start to produce antibodies against it, just like you would anything else. Okay, so you produce antibodies against the HIV virus initially. And this is going to allow some of these cytotoxic T cells to destroy, well, in this case, it would be actually destroying its own T cells. And the virus, for whatever reason, moves into a dormant state. And it stops replicating, and it will just sort of hide out in these cells. And that's so if we sort of go through what's going on, the primary infection, it's a little off guard. Okay, so the HIV is a little off guard, and so it's launching and so an immune response happens because of that. And then once it gets loaded up into some of these CD4 cells, for whatever reason, some of these will go dormant. And it will cause the cell to be dormant and inactive. Okay, so it's still a CD4 cell, but it's inactive and it's hiding the virus. So during this initial stage, you'll see signs of the systemic infection. So you'll actually see something going on, and the immune system will respond, and antibodies against the HIV will appear. And so that'll happen over the first 1 to 6 months. And then this latency phase, and this is where the immune system has a good response, and it takes out a lot of the infected cells, and it takes out the free virus. But then there are latent viruses, and these latent viruses will still replicate. They'll replicate slowly, and they will still increase, and they will still continue to kill some of these T cells. The problem is, and this continues on until the T cells, like we said, get below 200 cells per milliliter, and that's when you actually have AIDS. Now, the problem is that, well, if we look at what happens over time, we can see the viral load. That's the blue here. Okay, that's the viral load. You can see that initial exposure, you have just out of control division, and the cells can't respond. Your immune system hasn't responded. But then you do see Okay, so initially it kills a lot of these T cells. The T cells levels go down, and then you start to produce the antibodies, and the antibodies will increase or decrease the number of viruses. And once that happens, then you kind of have this recovery, this little bit of a recovery of the T cells. But then that kind of continues, and you sort of reach this balancing point where the HIV is still being produced, it's still killing some of the T cells, and the T cells just kind of decrease over time until you have what people say is full-blown AIDS. So during treatment, oh, okay, sorry, I thought we were ready to start talk about treatment. So common manifestations. Oh yeah, right. That's right. Because initially, and if you don't control the HIV infection, like if you don't take certain medications that we'll talk about, then you can kind of see that maybe initially when you're first infected, you'll see some kind of almost like flu-like symptoms: fevers, night sweats, diarrhea, fatigue, weight loss, lymphadenopathy, so swollen lymph nodes. So you'll kind of see that at at the first sign of infection, and if you don't treat the infection, you'll kind of see this. The HIV will kind of get a foothold every now and then and cause some of these symptoms. But after you've developed AIDS, it's kind of a different story because it's really not the virus itself that's causing a lot of the symptoms. And so we have what are called AIDS-associated illnesses, and those tend to be opportunistic infections, and a lot of them tend to be respiratory. So things like fungal infections or something like that, which the body usually is very good at fighting off, suddenly become life-threatening. And so respiratory infections, viruses, bacteria, anything can cause pretty severe uh, effects, and ultimately will cause death. So respiratory, gastrointestinal, nervous system, that's another problem with AIDS itself, is it starts to cause neurological damage. Malignancies, it's much easier for tumors to get a foothold because your immune system is constantly fighting against tumor production. Wasting syndrome, metabolic disorders. So lots of things will result once the immune system has been shut down to such a degree. So treatments tend to be, now hopefully if you were paying attention to how HIV works, most available drugs block reverse transcriptase. Well, if you block reverse transcriptase, then the HIV is going to have a harder time uploading itself into the host DNA. The trouble is usually that's already taken place. Okay, that's already taken place to some degree. So you can slow the progression, so it's not able to happen as well. So you can slow the progression, but you're not going to get rid of the virus that way. Entry or fusion inhibitors, remember I said that it had to bind on the surface first to move in, so the virus has to actually bind and then it's able to move in. Well, if we block it where it can bind, then the virus isn't able to move in. But again, once you've been infected, that's not going to get rid of the virus. So these are the things that are, so right now that's the main treatment, if you will, therapy for HIV, is to just kind of take that constant decrease in CD4 cells and try to kind of level it out as much as possible. So the goals of treatment tend to be to reduce the viral load. Okay, so if when the virus moves out, it's not able to infect other cells, the antibodies have a chance to kill it before it can get into other cells, then that's going to kind of keep it in check. You also want to increase the CD4 count, obviously. You want to increase that as much as possible or keep it as high as possible. You want to, this also makes sense, you want to reduce HIV-associated morbidity and mortality. So the infection of it and the death that's caused by it. And overall, you're going to improve the quality of life. Now, I will say that there has been a report that they have actually eliminated HIV in someone. It's still an ongoing thing, but what they did is they did exactly what this is doing, and that's where some of the research is, so it's not a bad thing to think about. They treated with anti reverse transcriptase, so they treated with reverse transcriptase blocking drugs. They also blocked the fusion so it couldn't infect new cells. But what's the problem? Latency. We have latent cells, and so these, if the HIV really isn't doing anything and it's just remaining latent and quiet, it's tough to do anything about that. So they killed, what they did with this treatment is they killed as many as they could, and then they activated the latent cells and tried to kill those too. Okay, so they activate the latent cells and then take those out as well. And so that seems to be a direction that HIV is going, and hopefully it pans out. But a lot of times they've also cured it by doing transplants. They've accidentally cured it in certain people by doing transplants. People have their go through radiation, it wipes out all of their immune cells, and then they get a transplant from a donor, and the transplant donor's bone marrow becomes the host's bone marrow, the recipient's bone marrow, and it doesn't have HIV in it. So they've accidentally cured it that way as well. So there's a lot of progress, a lot of reason to think that this might be something that we can get a handle on eventually, and we're learning a ton from it as well. Okay, so that's it for this chapter, and yes, that's it.